Yeah, that one. You tilt it forward. I've got all your books in the little head. That's it. Yeah. It's not that I want to look at you. It's just so that our people can see what you really look like and that you are a he-devil.
Take the Maxilon and yeah.
Right. Hi, guys. Good morning, good afternoon, good evening. Welcome. Thank you very much for joining us. We have, as ever, Professor James Neuberger and Collette Thain MBE. One is a chair of our Medical Advisory Board and one is our Chief Executive Officer. And as it comes through today's conversation, you can get to decide which is which. We'll have a vote at the end. Thank you very much for joining us today. As ever, if you're on Facebook and you have any questions, please do remember that it is on Facebook, which is a public forum. So if you want to ask any questions of a more confidential nature, then do feel free to come join us in the Click Meeting Room. If you're in the Click Meeting Room and English is not your first language, you've probably got better chance of understanding James's answers for one. What you can do is you can choose to translate the chat box, so you can choose your own language. So we will choose English, and you can choose a language of your choice, which means that if at any juncture you have a question you would like to ask, you can type it in your own language and we can answer it in English, and again you can read it in your own language. Okay, so it's a busy day today. Chief, how are you?
I'm good, thanks, Robert. And yourself?
Yeah, I'm good, thanks. I'm good. What about you, James? I hear you're getting back in it again.
Yep, been doing clinical morning, and yeah, it's quite nice, really.
Good.
Yeah.
Good. Okay.
Yep. Is it okay if I just start off? I've just had an email within the last hour. It's not a question, but I think it's something worth raising, James. A lady went to have an endoscopy and her varices banded, and everything was fine. She came home the next day. When she was eating, she was in pain. She'd had a leaflet to read, but it didn't say anywhere on the leaflet you should be eating soft food for a week after banding. So I would like you, hopefully you can confirm this to be the case, and if it is, then we should really include that in some of our writings. It's not something that I've heard that I can remember. Is that fair?
It's some years since I've done banding myself. It's not something that we normally think is necessary. I'll ask colleagues in Birmingham and see what they do, but it's not something that we normally do. Pain can be quite severe after banding. It's worse after when the varices are injected. It depends where the pain is in the back of the throat or down, further down the gullet. But if it's severe, then they ought to contact their doctor again.
Yeah. Okay.
Okay, perfect. Okay. So on the kind of specific side of things, James, I've got another question for you just before we get into the general questions. We've got somebody who's gone to a dentist and they've had concerns about taking a tooth out because of alendronic acid. So first question, I guess, is what do we know about alendronic acid, and does it have implications for bleeding? And secondly, is there any way to improve bone density without alendronic acid?
Yes, I mean, all drugs have risks. Some also have benefits as well. And whenever you're taking medication, you need to balance the two. Osteoporosis, and I will come back to your questions to answer them specifically, but osteoporosis can be very severe, can be debilitating, and can actually lead to premature death because it has it has several potential severe side effects. You can get thinning of the bones, particularly the vertebrae, where your vertebrae collapse, and it's very painful. And that's where you get the stoop people, the people who are very bent. And that can be very debilitating once the pain has resolved. The other major concern is increased bone fractures, and particularly hip fractures. And for many older people, a hip fracture, even if it's repaired or replaced very quickly, which is the common approach, is often associated with death because of the immobility, the chest infections, clots, and so on. So osteoporosis can be trivial, but it can also be very severe, and as I say, lead to pain, fractures, and particularly fractures of the neck of the femur in the elderly and the frail. Often leads to a premature death. What you can do to prevent it is, there are 4 major risk factors. There are a lot of other ones, but being female, particularly postmenopausal, is a major risk factor. Having cholestasis and liver disease is another factor. Smoking, a third factor, so don't smoke, another reason not to smoke. So not only if you smoke, you get wrinkles, you get vertebral collapse and a stoop. And also some drugs, particularly corticosteroids, prednisone, prednisolone. Other factors that are particularly important is a family history, and it can run in families. Not a lot you can do about that. Being adopted doesn't change your genetics. It may change your parents, but not your genes. And immobility. So if you have osteoporosis or risk, the 2 major things you must do, apart from avoid smoking, is to take plenty of weight-bearing exercise. So swimming is very good for you, but it doesn't really help the osteoporosis. So walking, jogging, that sort of thing is very effective. So plenty of exercise, and also calcium and vitamin D. We've talked about vitamin D, and there are many reasons why most people in the UK should be taking vitamin D, especially in the winter months. Good calcium intake, milk, or calcium and vitamin D tablets. You measure the degree of osteoporosis predominantly using a DEXA scan, which is a form of X-ray of the hip and the lumbar spine, and it will tell you the bone density, and it will compare it with 2 figures. One is the bone density compared with normal, and the second one is bone density for age, because as you get older, your bone density tends to reduce, and it's the bone density that leads to the predictor of fractures. So the main treatments to prevent, once you've got osteoporosis, it's quite difficult to reverse it. So prevention is important. As I say, exercise, calcium and vitamin D. And for those people with significant osteoporosis, or it's not stabilizing on simpler measures, alendronic acid is a group of drugs called bisphosphonates, which have been shown to reduce progression of osteoporosis. They do have a number of potential side effects, and bone and the jaw is certainly one of them. And I think that's why the dentist is cautious, because there may be jaw problems from the bisphosphonate rather than any bleeding issues. And therefore that's something to discuss with the dentist, to know what is the problem with the tooth, the risks. If the dentist is concerned about bleeding, well, bleeding in liver disease used to be very simple. We thought there was just an increased bleeding tendency. It's actually far more complex, because your body has, to stop bleeding, there are 2 types of mechanisms. The first is the platelets, which act, so if you have a small hole in, say, an artery or a vein, the platelets clump together and block it. And platelets may be reduced in people with PBC if they've got an enlarged spleen, for example. That usually doesn't matter, but the platelets are just mopped up. But some people are concerned about that. The other is the clotting system. And there's a very complex arrangement of prothrombotic, i.e. increasing the risk of clots, and the thrombolytic, which is dissolving clots. Because if you think about it, you want to get a clot forming where there's a leak, where there's blood coming out of the vessels. But if the clot spreads too far and too fast, your whole blood supply will clot off. And there's a very complicated system, which I keep on reading up and failing to understand. And in liver disease, that doesn't mean it's very complicated, I hasten to add. There's a disturbance of both the thrombotic and the thrombolytic pathway. And although we tend to measure it with the prothrombin time, that only measures the clotting time, not the thrombolytic time. So bleeding can be a problem in liver disease. It usually can be overcome. But if the standard clotting parameters, the blood tests, are outside agreed limits, then you need to go to a dental hospital to have dental tooth removal. Usually it's not a major problem because you just put pressure on the socket. So I suspect the dentist may be more worried about the effect of alendronic acid on the dental, on the bone in the jaw. And I think one needs to understand why the dentist is concerned and address that specifically. So it's an interesting problem. Normally, in my experience, people on alendronic acid have dental extractions without problem. So I wonder if the dentist has a reason for concern. And I suggest you go back and talk to your dentist, try and understand the nature of the problem and see how to circumvent it.
Perfect, that's helpful. Thank you.
I'm just going to add to that. The exercise, as you know, movement medicine is really my thing, and out walking, regardless of weather, is really good for you. But also to remind those, or to tell those that don't know, on Tuesday at 2:00, so Roma and I are coming in, Thelma and Louise. We're going to have the camera on Roma. She's a keep fit expert and an examiner, and she'll be showing you some of these exercises, weight-bearing exercises you can do indoors if the weather's too bad or you're a bit stuck for getting out. But we'll be covering all of these. And anybody who wants us to cover anything in particular, we've had a few replies already, please let us know, because this is really important. This is your overall health. And these are things that you can do to help yourself. So we're doing that Tuesday. And it's going to be Thelma Louise side. It's going to be fun. Okay.
And exercise is beneficial not just for bones, but the whole well-being.
Yeah.
And it releases endorphins, as you'll hear, and it's endorphins that lead to well-being.
Yeah.
That's why you get gym junkies, something I fought against for years.
No, but particularly in times as now, I mean, we're all struggling with the COVID and the lockdown and everything else. And it absolutely is lovely that there's just one thing you can do for yourself in your own way, in your own style. And it's nice to have that bit of power, I think.
And yeah, I mean, it puts it in your hands. And, you know, for example, in mild depression, again, it's very effective.
Yeah.
So don't underestimate the benefits of on mood, on well-being, general health, as well as your bones.
Mm-hmm. Yeah. Excellent. Let's see, we've got a question there on the screen, Robert. Just made we want to roll on to vitamin A and D.
Yeah, well, absolutely, because James mentioned it earlier. So if we can follow up. So we've got somebody who's deficient in both vitamin A and Vit D. Despite taking 50,000, I'm guessing that's international units of vitamin D weekly for months, it doesn't improve their level. Do you have any recommendations on how to improve vitamin D?
I think there's several questions that come out. Firstly, just to say that levels of vitamin D are not that precise. They're not that accurate. They're not as good, say, as measuring the ALT or the ALK phos. But nonetheless, if they're low, if vitamin A and D are low, one question that comes to mind is why? Is it the intake is inadequate, or is there a problem with malabsorption? And the several things that come to mind in people with PBC. One is the questran. If you're taking questran, that can interfere with the absorption of some of the vitamins. And it's important to take them at quite different times. Secondly, you can get conditions like celiac disease, where you get malabsorption. And that can usually be excluded by a simple blood test looking for the relevant antibodies. Sometimes people with PBC have low pancreatic secretion, and therefore they don't absorb the fats. And there are 4 vitamins that are fat soluble, A, D, E, and K, so that if your fats, instead of going to your body, go down the loo, the fat soluble vitamins will follow them. So is there fat malabsorption? And again, you can see that in anybody who's got significant jaundice or people who've got pancreatic problems, for example. So I'd want to know why there's A and D. Is there a medical or other cause? Is it drug interactions? And if it's not going up, then perhaps you may need more vitamins to kickstart it. But if it's A and D, I just want to know a little bit more to know why, exclude other causes. And if you're taking Questran, then think about taking your vitamins at a different time.
Can I point out something as well? Something that staggered me when I went for that DEXA scan. I mean, I was fine. I mean, I'm a large lady. Large people seem to do a bit better. But they now have you fill in a very lengthy questionnaire and quite a lot about your food intake, your diet, etc. And I do have a very good diet. Not perfect, very good. I was staggered to find that I was taking very little of vitamin D in my diet because I don't like dairy produce, etc. I was staggered. So it's worth also looking at your diet, go on the internet and find out what vitamins are in what foods, but it could well be it's added to, it's dietary also. It's worth a look, I think.
Okay, perfect. Thank you both. That's helpful. Next question for you, James. Nice general one for you. What is autoimmune hepatitis and what does overlap mean?
Right. The simple one is autoimmune hepatitis. And this is a condition where, for reasons best known to oneself, the body starts attacking the hepatocytes, the primary liver cells of the liver. It's an immune-mediated reaction, and the active immune cells, the T cells, start to damage the hepatocytes. In primary biliary cholangitis, if you remember, it's the bile duct cells that are predominantly attacked, not the liver cells, the hepatocytes. And this condition affects people of all ages, children as well as adults. And again, unlike PBC, which affects primarily adults. And although women tend to be more affected than men, it's still much less. The ratio is much less than it is for PBC. It is an autoimmune condition. There is a strong genetic association with it. There's an association with other autoimmune conditions. And the diagnosis is usually made on the liver tests, which are raised ALT or AST. In severe cases, the bilirubin may be elevated, so you're jaundiced. The IgG, one of the immunoglobulins associated with infection, is usually very high. And the autoantibodies, particularly the anti-nuclear antibodies, are usually increased also. You usually confirm the diagnosis on liver biopsy and also by excluding other causes, because some drugs can give you a similar picture, but if you take away the drug, the hepatitis settles down. Some viruses can mimic autoimmune hepatitis. But if it's true autoimmune hepatitis, then the treatment is with immunosuppression, prednisolone, and azathioprine, the cornerstones, but you can also use mycophenolate, cyclosporin, tacrolimus, and so on. So it's an autoimmune condition that usually responds to steroids. It's a lifelong condition for most people, and it's an attack on the liver cells. Overlap syndrome is different, And there's a lot of debate as to whether the overlap syndrome really is an entity or not. I think most people, Gideon Hirschfield, I think Dave Jones, who you're hearing from in another couple of weeks, George Mells and so on, would believe that it's probably part of the PBC spectrum. But the overlap syndrome is when people with PBC, so the anti-mitochondrial antibody with the raised ALK phos, they have features of autoimmune hepatitis. So they may have a raised IgG, but that's not specific. It's found in PBC without autoimmunity. And they may have anti-nuclear antibodies, but these are usually different anti-nuclear antibodies from those in PBC. And there may be inflammation on the liver. Some people believe it's a real entity and it's a crossover between two conditions and give steroids. Mostly one tries to avoid giving steroids because of their side effects and because they largely don't work. So my view, and it's not agreed by everybody by a long chalk, is that overlap syndrome is that people with PBC with a more inflammatory component, but they still have PBC. And to my mind, it's rather like saying that if you have a man who's got, I don't know, painted fingernails, which you associate more with women, although stereotypically, you don't say they're an overlap between men and women because they've got shared features. I think by and large, they're two separate conditions which should be treated separately. Steroids are rarely indicated in PBC or with overlap. They are sometimes, and they're mandatory in autoimmune hepatitis. So I think the overlap is when you have features of the two conditions, but I think it's just really some factors in common with the two conditions. So I think it's a non-disease, but there are quite a lot of people who have a different view. The fact they're wrong is irrelevant. I think once we know the cause of, there was a very similar argument with hepatitis C before it was identified, because some people with hepatitis C infection have autoantibodies and a raised IgG and so on. And there was talk about this with an overlap syndrome. Once they identified hepatitis C, it became very clear it was hepatitis C. You treated the hepatitis C, everything went away. I think once we know the cause of PBC and have a cure rather than a treatment, again, I think there'll be a similar pattern, but I'll probably be dead before that happens.
Oh, don't say that.
Well, I hope not. I hope it'll be discovered tomorrow, but sadly, it won't be me.
In which case, does it not concern you then? Or is it a concern that if people do have this overlap, they've been told they've got this overlap syndrome, they've been given the Urso, but they're also being given steroids?
Well, I mean, my own approach, and we had actually on Monday we had a case which I discussed, is that this was a woman again with PBC, a high ALT of 240 or so, high, but not worryingly so. She was on Urso, hadn't responded. Her ALK phos went down to 340, and I wanted to give her Ocaliva or obeticholic acid, not steroids, and I discussed it with Palek, who runs the MDT for it, and he agreed. And my guess is that on OCA, her liver tests will improve and her ALT will come down. But, you know, it's not entirely clear. As I said, I may be wrong. Certainly watch this space. But as I say, my own view is that not give steroids, but treat the inflammation in other ways.
Okay, that's helpful actually, because we get asked about it quite a lot.
Yeah, it's controversial. Yeah.
I was going to say pre-COVID, when there were still physical conferences, so things like EASL, ASLD, etc., a lot of the language was changing, James, and the presenters were talking about PBC with features of AIH. And that seemed to be the linguistic change, as if there is a change in the
So they're coming around to James's way of thinking then, Robert. It's taken them 30 years, but
I think you're right. I think it's accepting that it's not a separate condition. It's just a bit more. And my impression, and I haven't shown this, nor has anybody else conclusively, is that you get a spectrum of. I suppose another example is if you get, I don't know, a short race of people, and then you get a tall one. You say got overlaps with Swedes because the Swedes are tall. So I think you're right. I think the nuance is changing as people realise it's part of PBC, and you're not having to invoke two separate conditions, because autoimmune hepatitis is what we call a syndrome, which means you're making a diagnosis on a group of signs and symptoms, whereas with PBC, you're saying you're making on the basis of the antimitochondrial antibody predominantly, and supported by the other features. With COVID, you're making on the diagnosis of the RNA. Whereas with autoimmune hepatitis, it's a syndrome. And as I indicated, there are many causes of or some triggers of autoimmune hepatitis, some viruses, some drugs, some metabolic conditions like Wilson's disease and so on. And sclerosing cholangitis, another liver disease, again, in children presents very much as autoimmune hepatitis. But as the child grows, the condition progresses, they become very clearly into sclerosing cholangitis. So I think there are three different conditions that we don't have the diagnostic criteria for that are robust.
Perfect, thank you. So, I mean, it's busy in here, but it's particularly busy in Facebook, and we've got a lot of questions coming in. So I'm going to try and fire a few at you in quick succession. If okay.
I'll try and answer quickly, yeah.
So first question, any thoughts on actually, I'm going to stay with PBC and AIH. So I know that you kind of pointed to this, but the question is, why are there two different treatments for PBC and AIH? And I know you kind of alluded to that earlier, but again, just a little clarification would be helpful. And another question is, again, the thinking at conferences is that PBC and AIH overlap, inverted commas, is overdiagnosed. So if somebody has been told they have PBC and AIH, what can they do to clarify their situation and make sure that they're on the best possible care pathway?
Right. I think the treatments are very different because steroids and azathioprine or mycophenolate have been shown conclusively to work in autoimmune hepatitis. They control the infection, they don't cure the disease, but numerous studies in the 50s and 60s have shown that steroids save lives, reduce death, reduce progression of disease. Excuse me. Whereas steroids and azathioprine really have very little effect in PBC. Urso works effectively in PBC. It has very little impact in autoimmune hepatitis. So there are two different diseases, two different mechanisms, different targets, the liver cells or the bile duct cells. So there's no intrinsic reason really why they should be the same. I think and I suspect there are different triggers that result in the two conditions. I think in one respect, from the practical point of view, the patient pathway point of view, whether you call it overlap or whatever, or PBC with features of AIH or just PBC, what really matters is how you treat it. And the question is, with the overlap syndrome, in inverted commas, is really, do you want to give steroids? My own approach, I think, shared with some of the overlap skeptics, is if urso doesn't work, you go down the pathway of Ocaliva, obeticholic acid, or Fibrates, I suppose, are the next one. I'm not a fan of other immunosuppressants. Sometimes I do lose my nerve with very high transaminases and give prednisolone, but I think I'm treating myself rather than the patient. So I wouldn't get too hung up on the names, but the conditions really. And if you get a person with PBC with features of AIH, I think the first thing to do is to give urso, to give the proper dose of urso, 13 to 15 milligrams per kilogram, and go down that pathway. And only when you've exhausted that pathway would I start to give steroids, as a general rule.
Okay, perfect. Thank you. That's helpful. Chief, any thoughts?
No, let's get through them, Robert. I'm worried. I hate to think that people are left not able to ask their questions.
We will get there. So we're going to go into the PBC and section.
Yeah.
So again, are there any, any relations, any links, any, that kind of thing. So the first question would be PBC and raised lymph nodes near the liver.
Yeah. Raised lymph nodes, there are many causes of enlarged lymph nodes. It can be serious. It can indicate things like lymphoma. It can indicate tumors. It can indicate infections. It can indicate a response because, if you have an infection, and anybody who's had a bad sore throat may know this, you get enlarged lymph nodes, which are tender and painful, and that's a good thing because it shows your body is fighting infection, your lymphocytes are being produced to fight the infection, and so on. So in PBC, a lot of the lymph nodes, particularly around the bile duct, the perihilar so-called lymph nodes, are enlarged. They're not hugely enlarged, but that's quite a common feature of PBC, and it's nothing to worry about. I think if you do see enlarged lymph nodes in people with PBC, you just have to be aware of that. You want to keep your eye on them with ultrasound. And certainly if the person's unwell or they're growing, but the lymph nodes are growing, you might take it further. But often enlarged lymph nodes around the liver are a normal feature of PBC and of no cause for concern.
All right, thank you. Chief, I'm going to come to you in a second with the same question, but James, have you heard anybody talk about PBC and having a burning tongue as a symptom?
I think the short answer is no.
Okay.
No, I haven't had that either. No.
Okay, that's fine. So those of you that have that, maybe come and talk to us and let us know your experience and how that manifests.
And check it with your dentist.
So, okay, perfect.
And
thank you.
Use the app to let us know. That's the important thing.
Yeah, absolutely. Yeah.
Absolutely. Okay, next up is there a link between raised cholesterol and PBC?
Yes.
Okay, can you give us a little more information?
Cholesterol is complex, and essentially there's, to be oversimplistic, there's good cholesterol and bad cholesterol. In the normal population, I'm excluding people with PBC here for all sorts of reasons, physically as well, a high cholesterol is a good marker of a risk of heart disease, and treatment is certainly should be considered, and statins are usually wheeled out, and they're often the most appropriate. The thing in PBC is cholesterol is often increased because of a increase in good cholesterol, and overall people with PBC do have much higher cholesterols than the rest of the normal population, but, and an important but, they don't have an increased risk of heart disease. So if your cholesterol is raised, that's usually to be expected with PBC. What your doctors should be doing is looking at the components of the cholesterol, the HDL in particular, but the LDL and the other factors, and then making an individual risk assessment on whether they would advise you to take a statin or not. But the normal treatment algorithms that you'd use for somebody without PBC do not apply. But if you had somebody with a high cholesterol, fit, well, good HDL levels, non-smoker, not drinking, running around, good family history, then probably no statins. But equally, somebody with xanthoma, the cholesterol deposits, strong family history of heart disease, and a smoker, then statin certainly. So you have to look at the context of the whole patient. But the normal algorithms that the GP or hospital doctor would use for looking at cholesterol and then advising statins don't apply.
Okay, perfect. Thank you. Next question now is about pancreatitis. So, and again, I just want to check the wording. Does having PBC have any effect on chronic pancreatitis?
As far as I know, not. You can get an autoimmune pancreatitis, like you can get other autoimmune conditions in association with PBC. There's also a fairly recently recognized syndrome called IgG4 cholangitis, which again goes along with pancreatitis. And that can mimic PBC, although AMA are absent. And that usually responds very well to steroids. But a proper diagnosis of chronic pancreatitis is, as far as I know, not related to PBC. But people with PBC can have pancreatic problems in association with PBC, in the same way you get it with thyroid disease and so on. But I'm not aware that PBC causes chronic pancreatitis, or vice versa, indeed.
Okay, perfect. Thank you. Okay, next up, we're going into the PBC and COVID kind of bracket now, if we may. First question, are you aware of the Sinovac vaccine?
Yes.
Have you any thoughts on it? Because apparently there hasn't been phase 3 paper released yet. Unless, are you aware of anything? Can you tell us anything?
I mean, there are a number of vaccines that have been approved. And, if you're interested, look at the website where the Medical Advisory Board have put some guidance. There are different classes of vaccines depending on, for example, the AstraZeneca one is an mRNA one, Moderna one's an mRNA one, the Oxford vaccines are adenovirus vector, a sort of cold virus, if you will. They all seem to be broadly similar. The regulators, the MHRA in the UK, the FDA in the States, and the EMA in the EU, always look at drugs very carefully. They weigh up the benefits and the risks, and if they think it's appropriate, then they will license them. And of course, there are risks with any drug. And for example, a life-saving drug for cancer with high risk, you might accept, whereas a drug similar to paracetamol, but more side effects, you wouldn't take on. So all drugs, licensed drugs, have to be approved by the MHRA in the UK. And at the moment, these ones are not. But these are the regulators that look very carefully. They look at the raw data, because in clinical trials, drug companies spend literally millions, if not billions of pounds, euros, dollars, what have you, to develop these drugs, and they're going to do their best to give it a good gloss. The regulators are cynical people. They look at the raw data, and therefore one can be fairly confident that drugs and vaccines that are licensed have a well-established safety profile. It doesn't mean they're safe, but it means they're safe enough and for the indication used. So I think we will be getting more vaccines, and people will have heard in the news today that there's some suggestion that having different vaccines for your first, second, or subsequent doses may be of benefit. Who knows? The data's not there yet. So I think the more vaccines we have, it means two things. One is greater availability around the world, and that must be a good thing. And it also means probably prices will come down. The Oxford vaccine, I think, is £3. The Pfizer one is £38.
Because we do have one in Scotland. It's called Neuberger, because Bojo was up looking at the factory last week. So I think it's with the regulators now, I'm to understand.
So the more vaccines we have, the better.
Yeah.
And probably mixing and matching is probably going to be beneficial, but the data's not there yet. So only get vaccines that are licensed, I think is the key thing. You can get so-called vaccines over the internet. I think you're an idiot if you do that, because you don't know what you're getting. And certainly in the UK, the rollout's going pretty well.
It worked for me for my negative test result. I got that off the internet, no problem. I shouldn't joke. I'm sorry. Right. Okay. Thank you. Right. Next question. With regard to vaccinations, if you have portal hypertension and/or cirrhosis, would you be able to speak about getting a vaccination earlier? Would you be able to help you move up the groups?
That depends how bad your liver is. The fact you've got cirrhosis probably wouldn't necessarily move up the group. I believe, because I spoke to one of my patients this morning in clinic, I think that if you think you should be vulnerable, I think there is a mechanism in the NHS where you can apply to jump the queue, as it were, from your age and other conditions. So I think you're probably not extremely vulnerable, and therefore you probably won't be jumping up the queue. But go online. I'm sorry, I should have done this in advance, but there may be a mechanism for asking to have preferential treatment. But as we said before, most people with liver disease who are not immunosuppressed aren't at greater risk or significantly greater risk. The two biggest factors in the UK, according to a nice paper in Nature, age, far and away the greatest. The second biggest risk factor is being male. And then below that is ethnicity, social deprivation. But again, it's the men who are more at risk than the women.
Okay, perfect. Thank you. Next question. Can COVID lead to PBC progressing quicker?
Not that I know of. I suspect there haven't been enough cases to answer that question. But one thing I would say is that for anybody who becomes unwell with liver disease, who becomes significantly ill, the liver tests often do deteriorate. And that usually is an inflammatory response which settles down once the infection's under control. So if you have COVID and your liver tests do get worse, I wouldn't be surprised. I'd watch them carefully, of course, but I would anticipate that they would improve over time as the COVID infection settles down. But I don't know of any evidence that it would speed up the progression of PBC. Okay. It's an interesting question, but I don't know of many people with PBC who've had COVID, but there must be quite a lot around the world.
Yeah, we've had quite a few now. Quite a few come into our sessions and phone us.
Yeah.
Okay, thank you. So last question on COVID, because we do have a few more questions that I want to squeeze in. Again, there's an article that did the rounds that COVID can trigger autoimmune responses, and people with autoimmune disease could become worse with COVID. Do you have any comments? And I know the guidance is there, but again, maybe point people to the guidance that we have, but also if you have a short answer, that would be perfect. Thank you.
I mean, certainly some viruses can trigger autoimmunity. As I mentioned, hepatitis C can do that. Other viruses hepatitis A can do that as well, for example. Often with those, when the virus gets cleared, if it does, the autoimmunity goes away, but not necessarily. And it may be that in a genetically susceptible individual, a virus or other toxin can trigger PBC. So it's quite, or other autoimmunities. I wouldn't be surprised, but as you say, there's nothing clear in the literature suggesting it does do that.
Perfect. Okay, that's helpful. Thank you. For those of you that are watching on Facebook, just to let you know, now this could be good news or bad news. It's entirely up to yourself, but somebody in Click Meeting has shared with us that they've heard that burning tongue being talked about as a menopausal symptom. So again, I'm just putting that out there. It's a shared patient experience, so I thought I would share that with you. Next question I have. How often should you be having your liver tests taken? And is there a time where it's too long, if that makes sense? Because somebody's not had their test for a long time and they're now starting to get concerned. So again, what would you recommend in terms of gap between liver tests? And if you've not had a liver test, what can a patient do about it?
I think the interval between tests depends very much on the individual. Somebody who's got AMA, positivity, no evidence of fibrosis, is on URSO with a good response. Maybe once a year is probably, it may well be enough. Equally, if you've got advanced liver disease with jaundice, then maybe every 6 weeks or 3 months. So it depends very much on the clinical situation. If you're well with good liver function, liver at an early stage of PBC annually may well be adequate. If you're on URSO, again, you have to think, why are you doing the liver tests? Is it to see if you're getting to a more fibrotic or cirrhotic stage? Well, there are other ways of doing that with fibroscans, ultrasound, blood tests, ELF, and so on. So I think it depends why you're worried. But normally, if the interval is longer than 2 years, I would start to ask to have it repeated. But you've got to be guided by the individual. Somebody who's well, just AMA positive with normal liver tests on no treatment, maybe every 2 or 3 years is adequate. So it depends on your condition. But if you're worried, talk to your doctor. And it's not a big deal having liver tests. But then you think, what do I do with the answer? And if you're not going to do anything different, then why do it? If you're thinking, am I getting cirrhotic, then you may want to look at the albumin, to look at the platelets and so on. So it depends on the individual. But if you're unhappy, contact your doctor and ask them. Sometimes things slip through the net, but very often with very early PBC, you want people to live normal lives and as far as they can, not let it label them or determine who they are, and therefore not do too many blood tests. But if you're unhappy, talk to your doctor, talk to your nurse, and ask them for your particular case.
Perfect. That's helpful. Thank you. Next question, again with regard to spacing. So I've got questions about spacing URSO. So the first question is, some people say space your URSO through the day. There's now been a recommendation that you take all your URSO with your evening meal. So any thoughts about that? And the other question is, any thoughts about spacing ADCAL with URSO?
I don't know what the advice is on ADCAL and URSO. I wasn't aware of any particular advice on its basis. There's been quite a lot of work in the early days about whether you give URSO with meals, without meals, spread throughout the day or in one dose. My own feeling is that it probably is not that critical, and I'd go with whatever suits your lifestyle. If you're getting bloating from the URSO, then space it out seems sensible. in general, what I suggest is that you take it either when you put your teeth in or when you take them out. Collette will know what I mean. And
he speaks from experience.
In the sense, because I don't take Urso, it's because I don't take my teeth in and out. That's correct. But, no, I am personally not too struck on that. I don't know. I'll have a quick. There's any recommendation about Urso and calcium and vitamin D. I'll try and find out, and if Robert's got your details, I can let you know. I wasn't aware of it, but it doesn't mean it's not there.
But going to the Urso and how you take it, if you're anything like me, I mean, I take 5 a day. Do I want to take it 5 times over the course of the day and not remember to take that one? No, I don't. I just take it all at once. Have my breakfast, take the lot. That's over and done with. But as James says, you get bloating, do space it out. But I've been told for years it doesn't really matter.
Perfect. Thank you. That's helpful. Okay. Next question. Somebody's got high blood pressure. They've been prescribed candesartan.
Yep.
Maybe. Candesartan. 4 milligrams. Will this medication affect LFTs in any way?
It shouldn't do.
Okay. Perfect.
High blood pressure is very common, isn't
it? Yes.
It is working here. Okay. So I'm still giving you space to check that up, James.
Yeah.
So I've now got two last questions I really want to try and squeeze in if we can. So the first one is to do with acid reflux and the pain that comes from that. So somebody's already on 40 milligram omeprazole and they're on Gaviscon liquid, but is there anything else they can do to help the reflux and the reflux pain? And there's anything practical they can do that isn't necessarily to do with medication? So I'll come to you first, James, and then come to you, Chief, because I know you've got some thoughts on that. So James?
I mean, I think the first thing to make sure is there's no other pathology and one's excluded infection, inflammation, and other problems in the gullet. And certainly things like Candida can. So one needs to be sure there's no other pathology other than reflux. And that's a very important point. Mm-hmm. There are lifestyle changes that you can do. Certainly if you're overweight, to lose weight, to avoid smoking, to avoid too much alcohol and caffeine, all those can increase reflux. Not wearing tight clothes, particularly around belts and so on, sitting upright in bed, all those issues can help some people. But I think I'll leave it to Collette to carry on. But I think the key thing is to make sure that there's nothing serious or occurring other treatments going on in the gullet at the time.
Yeah.
Mm-hmm. Yeah, that's right. I mean, there's various things. There's a lady in here today, I saw her name, and she's recommended peppermint oil capsules, which I found quite helpful. But you know what, and I suffer something similar, and I know other people do, but believe it or not, I mean, everything that James has said is absolutely quite correct. Do you know, sipping warm water and it releases quite a lot of it. So you could be trying that, but I think it is important that you find out there's nothing else going on. I mean, the Gaviscon, I mean, that's quite a lot of omeprazole, isn't it? 40 milligrams. But yeah, I would recommend peppermint oil and sipping warm water. You know, boil the kettle and have a mug, you know, as you would tea, and do that. Another thing James said about caffeine, because we were all told, you've got PBC, so drink 6 cups of coffee a day. It doesn't matter whether you have caffeine or not, was what I was told. But when I started the caffeine and I was taking very strong coffee, because I like very strong coffee, that certainly made the problem much worse. So watch your caffeine as well.
I've just had a quick look up. The only thing I could see about calcium and Urso was calcium antagonists, which is a group of mainly blood pressure tablets. That's nothing to do with calcium, vitamin D. Whether that was a misunderstanding, whether there's more to it, I still don't know. So just an aside to the previous question.
Okay, that's perfect. That's helpful. And last question, James, but is a bit of a cracker. So I know it comes up on a regular basis. So we're going to look at pain relief or analgesia. And I guess I have two questions for you. So we're looking at pain relief that goes above and beyond. So if a couple of paracetamol is not cutting it. So if you're living your life in daily pain. And my question part A is if you just have run-of-the-mill PBC, and then question part B is if you have, say, cirrhosis, what can be done, what is the best thing that patients can do to help themselves, what should they be asking about or for from their clinicians?
All right. The first thing is pain is very debilitating. Chronic pain is very debilitating and makes you feel lousy. I was going to say shit, but that's not very medical. Second thing is to think, why have you got the pain? What's it due to? Is it just wear and tear like arthritis or osteoporosis or whatever? What's the cause? Often you don't find it, but you need to think, is there a serious cause for that pain or not? For normal aches and pains, for anybody with any stage of PBC, paracetamol up to 6 a day is safe. After that, it's difficult. Consider topical treatment with ibuprofen gel or equivalent, that heat, cold, physiotherapy we've talked about. If those measures don't work, then it's a much more of a challenge. And you need to talk to your GP. Certainly with advanced liver disease, we are very cautious about non-steroidals like Brufen. They're good analgesics, but they can cause inflammation of the stomach and bleeding. They can deteriorate the kidneys, and long-term non-steroidals in themselves can lead to kidney failure. You can try and mitigate the effect of the analgesia with drugs such as low-dose amitriptyline or gabapentin, pregabalin, that sort of thing. But if it's not responding to simple measures, then you need to talk to your GP, talk to your hospital doctor or nurse, again, review the cause, and if necessary, you have to go on to the stronger drugs like DF118, like so on, but they can be addictive. So it's a minefield if paracetamol doesn't work, but think of physical treatments if they're right for you. But you need to know what the cause of the pain is. And I think amitriptyline is probably underused. It's a way of, I think, making analgesia more effective.
Okay, perfect. Thank you. Okay, that's fine. I think that's us.
I would add to that, James, just to reiterate about physiotherapy. Because it really is always worth chatting to a physiotherapist about any kind of pain. And people who suffer nerve pain for different reasons, they have techniques. One of the nurses was telling me they have neat techniques to help with nerve pain, not just joint pain and all sorts of things. So it's always worth a wee bash.
And that's a great point. I was going to ask about pain clinics and looking at more the neurological side of pain. James, any thoughts? Because you obviously would know much more than I do.
Would know. I mean, pain, there's a very strong element, subjective element to pain. People can only, two people having the same procedure, the same injury, can have a very different response to pain. It's complex. If I say psychological, that's not in a deleterious sense. There are many factors that affect the severity of pain. And so it's a holistic thing. You've got to look at the whole patient. Neuropathic pain is different from arthritic pain, is different from cancer pain. Pain clinics are getting increasingly good, but there's often long waiting times. And even too much of the strong morphine type drugs, they get broken down and their metabolites can cause pain. So sometimes the treatment of severe pain is actually to stop the strong painkillers and so on. So if it's complex, your comment about a pain clinic is absolutely right. but there's often a long wait for them. But people are getting a lot better at treating pain, and it's multifaceted. It's not.
Can I add on to that, James, to say that pain clinics, which I think are marvellous, they are a 6-week session, so you would go once a week for 6 weeks. And the experts they have there are occupational therapists, physiotherapists, psychotherapists, medical doctors. They have everyone there that you can imagine. And as James has actually said, it's holistic. Every aspect is covered, and I can't recommend them highly enough. I think they're absolutely one of the brainchilds of this country. They're fantastic. So, albeit there might be long waiting queues in some places, maybe not so much in others, always worth getting. They will assess you. You'll be assessed, and they put you on a waiting list. It's worth doing if you have long-term pain. I highly recommend them. I'm not saying it'll be 100% for you, but you will learn an awful lot about your body and what can help and what you may be unconsciously doing to make things worse. So I highly, highly recommend them.
Perfect. Thank you, Chief. That's important. So thank you for sharing that. Yeah. Right. So I have to excuse myself and go and warm up my kazoo for 4 p.m. chat session.
So you're playing your kazoo this afternoon.
I think that's a euphemism I haven't come across yet. But,
oh, jolly good, Robert. Thank you so much. James, as always, thank you. And I'm sorry we've caught you on a working day as well. You'll be exhausted after. No. You get to your age and you put your feet up and get the fire going and get the pipe out.
I think a bit more hepatotoxin, I think, is...
hepatotoxin. No, I'm so I did dry January. I'm just weeding into dry February. Not difficult, you're a PBC patient. But James, thank you so much.
Thank you.
But everybody, you know what I'm going to say to you. Thank you for joining us. If you can donate, go to our website and donate, because these things are pretty expensive to run and we're determined to keep them going. So I will see you on Monday. Tuesday, I'm going to be here 2 o'clock our time for exercise, and I'll see you Wednesday. You'll have Robert in the meantime. And thank you so much for joining us. And thank you, gentlemen. It really is very kind of you to give us your time. Robert, thanks for your expertise.
So all I do is hit the buttons.
Well, good luck with the kazoo, whatever a kazoo is. Bye, everybody, and thank you.
All right, take care. Bye now. Thank you.
Bye now.
Thank you very much, James. I appreciate it.
Okay, thanks. Take care.
And you.